says identify and describe the following. That's where I'm going to start reading. The inspiratory filter. It says to follow the manufacturer's guideline for the type of bacteria filter to place on the inspiratory port. Now when you're putting something on a ventilator, every ventilator is going to be different as far as where the air comes out to go to the patient. It's called the inspiratory port. On the servo I, it says inspiration, and it has an arrow pointing to the patient to show that the arrow is going to be going into the patient. So that's where the fresh supply of air comes out of the ventilator to go to the patient. So that's the inspiratory port. And there's going to be a filter placed on it. So when you place a filter on it, how do you know when you take it out of the package if it's a filter or if it's a heat and moisture exchanger? And sometimes the only way to tell is by reading the package insert. And it'll say breathing filter. And it'll tell you how efficient it is on the package insert. Sometimes when you're looking at a heat and moisture exchanger, this one's kind of obvious because it says HME, but they're not all that obvious. So when you're looking at it, it's like, well, which one's a filter and which one's a heat and moisture exchanger? So again, it's the package insert that will give you the clue. All right, so the air coming through the machine and going to the patient, we want to make sure it's clean air. So that's why we're going to put a filter on. Inspiratory limb. So I'm going to show you the tubing. It says the inspiratory side of the circuit brings a fresh flow of gas from the ventilator to the patient. The filter traps bacteria and viruses that are 3 microns in size and larger. Identify the inspiratory side by locating the temperature sensing port. Okay, there's a sentence in there that doesn't belong there. It's wound up by the filter. So the filter traps bacteria and viruses. That's supposed to be up where we were just talking about the filter. Now I'm going to show you the circuit. This does not trap bacteria and viruses. Again, that sentence is in the wrong spot. All right, so we have 2 tubings. So one is inspiratory and one is expiratory, meaning that when the patient exhales, instead of the air going through the same tubing, it's going to go through the other side of the tubing. All right, so looking at the circuit, does this plastic piece look like a letter to you? Does it look like the letter Y? And it's called a Y. So sometimes it's spelled out W-Y-E, you'll see it in your textbook, or it just shows like a capital Y. So that's what it's talking about, is this part of the circuit. So on the Y, there's some places to connect tubing. The place that connects the temperature sensing port is pretty standard, and it's always going to look like this hole. And where you see that, you know that's going to be the side of the tubing that's going to bring your fresh flow of gas from the ventilator to the patient. So temperature sensing port, that's going to be your inspiratory side. It's going to be the inspiratory limb, it's also called. Right, so when the patient exhales, again, the exhaled air is going to go through the other tubing, and it's going to be this side. This has a pressure sensing line on it. Can you see the difference? How you could slide tubing onto this one? Where the temperature sensing port, you can tell you have to put something into it. All right, this is for sensing pressure at the Y. Most of the new ventilators now do not use this. So if you see it on the circuit, it just stays capped off. And you attach nothing to it. It just kind of stays there, but you don't use it.
What is this called?
Pressure.
Pressure.
Sensing port. So the inspiratory limb tells us to connect it to the ventilator. When you're connecting any tubings or any connections in respiratory therapy, it's always going to be with a push and a twist. Every single connection, push and twist. If you just set it on and you don't twist, it's going to pop off. And of course, if it pops off and the patient isn't getting ventilated, then that's kind of serious. So it's always a push and a twist. But guys, don't make it so tight that the girls can't come along and get it off again. So it needs to be a firm push and twist, but don't jam it really hard where nobody can separate it. So watch those muscles here. All right, what does it say after inspiratory limb?
Expiratory limb.
All right, the expiratory limb is connected to the ventilator, and exhaled gas from the patient will go inside the ventilator where the exhalation valve is located. Although not visible, the valve closes during inspiration, so the flow of gas can only go into the patient's lungs. It opens on exhalation to allow the gas to leave the patient's lungs. It also has transducers, which monitor flow, pressure, and volume. This is kind of wrapped around pretty good. If I show you this cassette here, there's really not a whole lot to see when I open it and bring it out. So the exhaled air will come in here. This is inside where the exhalation valve is located. So it's blocked off during inspiration. So all the air gets diverted into the patient's lungs. And then it opens on exhalation, and the exhaled air will come out. And then it'll exit to the atmosphere. Oh, I'm sorry. Right. So when it comes out from the patient and goes into the machine, we want to filter that gas too. So if they're exhaling bacteria, viruses that we don't want to breathe in, it's going to get filtered before it goes out to the atmosphere. So if you're in a respiratory isolation room, it's not like the room is full of, let's say it's tuberculosis, because everything will get trapped in this filter. Of course, when we're in the room, though, we still have to follow the respiratory isolation guidelines, but the filter will filter out all of the bacteria and viruses. So we're going to connect with a push and a twist, and that's going to take our exhaled air from the patient out to the atmosphere. Expiratory water trap and expiratory filter. The purpose of the expiratory water trap and filter is to collect condensate and other liquids. This will help to prevent the exhalation valve assembly from getting moisture on it. Moisture can interfere with the accuracy of the measurement of the exhaled air. So the dimensions on it. All right, so I didn't add a water trap. But on the other ventilators, we're going to see how they have a water trap on it. So the moisture from the patient's exhaled breath, if it gets inside, it just makes it, it interferes with accurate readings for pressure and flow and volume. So that's why we don't want to get a lot of water or moisture inside the ventilator.
Well, it needs electricity, no?
What's that?
It's also electricity in there. You don't want water in there.
The transducers have electrical current, yes. So could that cause, if there's water in there, could you get electrocuted? I don't think so. Never heard of that happening. I just know that it doesn't function properly. The patient Y and rebreathed air. Is that what you have next? You don't have the same one. Find the Y in the patient circuit. You found it already?
Mm-hmm.
Air in the ventilator circuit that is between the Y and the endotube is rebreathed by the patient. For this reason, it is also referred to as dead space. And then it tells you to describe the devices that cause dead space to increase. Let me give you an example. All right, so we're going to attach the ventilator circuit to the endotracheal tube. And anything that we add between this fresh flow of gas and the exhaled gas is going to get rebreathed. So Patient exhales. The next breath comes in, all the air that's in between is going to get rebreathed. For example, when we have a heat and moisture exchanger, this only adds like a few mLs of dead space. All right, so now between the Y and the endotracheal tube, notice how we have some devices, and all of that is going to have air in it. So when the next breath gets delivered from the ventilator, all of this air that's in here will get redelivered to the lungs. So it's considered dead space. Next sentence. Explain why it is necessary to have no leaks in the circuit. And then it explains it. Instead of the air entering the patient's lungs, the air will exit through the leak in the circuit. This will cause less air delivery to the patient's lungs. So when we set up a circuit, we can't have anything open because when the air gets delivered, instead of it going to the patient's lungs, it's going to go out the leak. So let's say this fell off, and now it's time for the ventilator to give a breath to the lungs. Yes, a little bit of air will go to the lungs, but most of it's going to come out this leak, or this hole in the circuit. So it's really, really, really important to have no leaks in the circuit so that all the air goes into the patient's lungs. How should a ventilator circuit be handled to prevent contamination? It tells you to use clean technique and only touch the outside of the circuit. The inside of the circuit must be kept free of any contamination. Handle the circuit carefully to prevent the ends of the circuit from touching any objects. So the circuit is long, and if you're my height and you're holding the circuit, one end is going to drag on the floor. So what you can use are the arms that come with the ventilators. Some of them work, this one just works by pulling on it. Some of them you have to loosen each side and tighten it to get it where you want it to go. So use the arm so that the circuit isn't dragging on the floor. Now if it drags on the floor, what should we do with the circuit?
Change it.
Should we throw it in the garbage and start over again? Yeah, so with neonates, with pediatrics, that's the case. They're so susceptible, their immune systems are not developed well. If the circuit touches the floor and the circuit becomes contaminated, you throw it in the garbage. With the adults, if a tubing drags on the floor,
Just change the filter.
like let's say this dragged on the floor. You can get alcohol. Alcohol wipes are in every drawer in every room in the hospital. Keep a bunch in your pocket. And you can alcohol the end, let it dry, and then you can use the circuit. But I mean, if the floor is wet and full of blood and it lands in something like that, throw the circuit out. But if it briefly touches, you pick it up, you have to alcohol it before you connect it. How often should a ventilator circuit be changed? The Center for Disease Control recommends the circuit be changed on an as-needed basis, which is abbreviated PRN. If the circuit is visibly soiled, it is recommended that the circuit be changed. All right, so the hospitals that you go to will have a policy for when the circuit gets changed. Usually it's 30 days. Or if it's contaminated. So if you see mucus in the circuit, it's usually what contaminates it. Sometimes patients coughing up blood and blood gets in the circuit. In that case, you change the circuit. And it used to be where the circuit was changed every 24 hours. First thing in the morning, we'd start our shift, we have to put a clean circuit on the ventilator. It was believed at the time that the reason patients are put on a ventilator and they have pneumonia within a day or two is that the circuit is contaminating their lungs. Well, over the years, they found out that no, the contamination is not coming from the circuit, it's coming from the oropharyngeal secretions that drip down past the endotracheal tube. And that's what causes them to get pneumonia after they're on the ventilator. So then they found that the less the circuit gets changed and manipulated, the better off we are as far as pneumonia developing with the patients. So now that's why they say PRN or every 30 days. How is a ventilator circuit disposed of? Ventilator circuits are for single patient use. Some added devices may be reusable and need to be sterilized before use on another patient. I'll show you the Untitled CO2 monitor. This adapter can be sterilized, so you send it down to central sterilization at the hospital, and then you come back out sterilized. A used circuit may be disposed of in the regular trash. However, note the following exceptions. If the circuit has visible signs of blood, the circuit needs to be disposed of in a red bag. Red bagged contents are incinerated instead of going to a landfill for disposal. If a patient is in isolation for any reason, the circuit needs to be disposed of in a red bag. So you'll see garbage cans at the hospital that'll have like a regular garbage bag, like, you know, clear or white. And then you'll see garbage cans with red bags in there, and they're pretty thick plastic. Anything that goes in there does not go to the regular landfill. It'll go to an incinerator and get incinerated. So if the circuit has blood in it, it goes in a red bag. If it comes from an isolation room, it goes in a red bag. Otherwise, it can go in the regular trash. Will bacteria grow in the humidifier and contaminate the patient's lungs? So we don't have a humidifier on because we're going to be using a heat and moisture exchanger. But over there, we're going to put on the heated humidifier. Although the humidifier chamber is initially filled with sterile water, bacteria will not grow if the water temperature is kept higher than 42 degrees Celsius. A cooler temperature may allow bacteria to grow. However, these bacteria will never reach the patient because water vapor is too small to carry bacteria through the circuit. So when you're using a heated humidifier and you have that little reservoir of water, is it possible for bacteria to be growing in that reservoir and then to travel through the circuit to the patient and contaminate the patient? The answer is no. Water vapor is molecular in size and it cannot carry a bacteria. So any contamination that may build up in that humidifier does not get to the patient. And it says how to place a circuit with a heat and moisture exchanger on the ventilator. Connect the circuit and filters to the ventilator. All connections in respiratory care are done with a push and a twist. This will prevent accidental disconnections. You may also want to be able to disconnect the connections, so never use force to connect the tubing. Show the placement of the following. And the first one mentioned is the heat and moisture exchanger. It tells you to place the HME in the circuit so that exhaled air will pass through the HME as well as inspired air. So could I put a heat and moisture exchanger on the inspiratory side of the circuit? No. That would have to go in the garbage. Could I place it on the expiratory side so that it collects all the warmth and humidity? No. So it has to be placed where you're going to get inspired air and exhaled air. So the exhaled air, it's going to trap the moisture, the heat, and then the next breath will come in and deliver it. So it has to be where it's going to get up. Although an HME is at best about 80% as efficient as a heated humidifier, it is used on patients who are on ventilators, even if they are on a ventilator for a long period of time. And that has become an issue as of late. It seems like there's been a trend in respiratory where years ago everybody was on a heated humidifier, with the water chamber and the heat to deliver the moisture. Then they said, well, that's not necessary. We can use a heat and moisture exchanger. So then you see all the hospitals slowly switching over and everybody gets placed on a heat and moisture exchanger. Now they realize that the reason that patients are developing pneumonia is that their secretions are so thick because they're not being humidified adequately, and that's what's causing pneumonia also. So we've got the oropharyngeal secretions, we've got retained secretions that are really thick because we haven't humidified them correctly, and now the patients are getting pneumonia. So some hospitals, you'll see them use the heat and moisture exchanger on the patient maybe for the first 2 to 3 days, and then after that, it's the policy to switch over to a heated humidifier. Were you seeing that anywhere, Raymond? Was Memorial doing that, or Broward?
Memorial was all HMEs. Broward, after a couple of days, was switched to
A heated humidifier? Okay. So Broward is switching. HME traps moisture and warmth from an exhaled breath. The moisture and warmth will be redelivered to the lungs when the inspired air from the next breath passes through the HME. Adding an HME increases the amount of dead space in the circuit. Does that make sense? Because it's between the Y and the endotube. HMEs also increase the patient's work of breathing. This increased work of breathing, because it's resistance, occurs when the patient attempts to pull in their inspired air through the HME. So when this gets saturated with moisture from exhaled breaths, it does create some resistance when the patient breathes through it. Not a lot, but it does create resistance. Select an HME that can be bypassed so medication can be delivered to the patient. Keep in mind that medication cannot penetrate an HME. Either a standard HME will have to be removed while the medication is being delivered, or an HME that has a bypass feature should be used. And that's what we have in the lab. This says HME, but when you twist this blue piece of plastic, now it says aerosol, meaning that instead of everything going through all these filters, it's just going to go through the center. So this is how you would set it up if you want to deliver medication. You would twist it so that it says aerosol. And then when the treatment is finished, then you switch it back to HME so that the patient's getting moisture with their inspired air. Okay, now it talks about an inline closed system suction catheter. It tells you to place the inline catheter along with its adapter directly on the endotube. So inline suction catheter, and this blue portion is considered the adapter. There's one company that makes them separate, but the ones that we have in the lab, they're all together. There are some interesting features of the adapter that holds the inline catheter. The swivel is designed to prevent the endotracheal tube from being pulled when the circuit is moved. So this swivels when it's attached to the endotracheal tube. All right, now when the tube moves in the patient's mouth and in the back of their throat, it's really uncomfortable. Just having a plastic tube in their throat all the time, it gives them a constant sore throat. So they're really sensitive, like if you try to suction them out and keep a lot of secretions from building